All right, the facet joints. For most people that have kind of an acute bout of back pain, especially whenever they feel like their back is kind of locked up, this is what we think is the culprit. Now, facet joints are most easily understood if you just look at what they do whenever we take a spine model and you move the spine model, all right? Now, if I were to just pose a question to the audience here, do we have more range of motion in flexion or extension of the spine? In flexion by a long shot, right? And that's actually, whether by design or by evolution, it's supposed to be that way. What these facet joints do is that they actually allow us to move. We are actually allowed to move our spine because we have these facet joints. Okay, not the only reason, but it's a large portion of the reason why we're able to have the motion in our spine that we do. If we didn't have the facet joints, if we would have more of like a bamboo type spine, right? That we would be able to maybe cause some deformation of our spine with really strong muscular contractions. But the reason why we have the freedom of movement that we do is these little facet joints. Now, every vertebrae articulates or joins with the vertebrae above and below using these facet joints, all right? And what happens, depending on where you look in the back, they have a little bit different orientation, but whenever you look at the lumbar spine, they're kind of like this, all right? Kind of at an angle. What happens whenever you flex forward is those facet joints open up a little bit. So you go like this, those facet joints open up. Whenever you go back, those facet joints push against each other, all right? So if I ask the question, say whenever you're bench pressing, right? Are you more stable in a little bit of flexion or are you more stable in extension on the bench? You're much more stable with extension on the bench, which is one of the reasons why we teach having an arched back. Because you bring yourself into extension, those facet joints butt up against each other and they don't allow any shear movement of the vertebrae. Now, if we just said that by extension, you don't allow any shear movement, what happens whenever you're flexed forward? You flex forward, these joints open up a little bit, and that allows one segment to translate horizontally on the other segment a little bit. Now, discs are very good at handling compression, but they're really not as good at handling compression and shear. All right, and so a lot of our disc pathologies we think is either a culmination of repeated flexion or it's compression and shear forces. That's why whenever you're doing a squat and as you go down, you kind of hunch forward, you kind of lose back tightness and you tweak your back. That's why, because as you go into flexion, your spine becomes more unstable because it allows some degree of shear force through these facet joints, all right? Now, I'm going to tell you this, and there's really no evidence to say that this is what goes on, but this is kind of what we think of in the physical therapy world, right? That these joints have a little bit of, you can almost think of it like a meniscus. It's a piece of cartilage. It's called a meniscoid, and it's surrounded in, just like every other joint, it's surrounded in connective tissue. Now, if this is surrounded in connective tissue, to allow the freedom of movement that we have, there has to be some redundancy in that, right? If the connective tissue fits real tight around that facet joint, you wouldn't be able to move. But if there's more connective tissue than if there's some open space in there, then now it can move a little bit, right? Kind of the same thing with the shoulder. We have the range of motion of our shoulder because of a very large joint capsule relative to the size of the joint, all right? So whenever your back kind of locks up and you get this real sharp kind of unilateral pain, what we think can happen, and this is one of the ways that we treat acute onset unilateral pain, is we think that as you did whatever task and you felt that back tweak, that there's either a displacement of that kind of meniscoid structure or that you caused some of that connective tissue to kind of find its way inside of that facet joint and then you slam those together. Now, once that happens, you're probably going to have some back spasms because the body doesn't like smashing connective tissue, right? Whenever the body realizes that there's something awry, then the body uses spasm to kind of protect that area, all right? So whether or not it's ever been proven, it's never been proven, all right? But from the physical therapy standpoint and from the chiropractic standpoint, we use that model to kind of guide our treatments. And I think, you know, for acute onset back pain that's unilateral, like we're pretty good with treating this stuff with manipulation. You come into my clinic within about 2 weeks of having that back pain, I can usually pop your back and send you on your way and probably never have to see me again, all right? But that's what's going on with that, and that's why these facet joints are really important, all right? And why for us, whenever you have somebody come in and they say, yeah, you know, I had a kind of bombed out on a squat yesterday, and man, this right over here, it really hurts. And it hurts whenever I move and I don't feel like I can bend back or whatever. Tell them, just go over there and just kind of do that. And guess what? Now they feel a lot better. Or this is a perfect opportunity for this person to go pay $30 at their chiropractor, and they can get back to training almost immediately, all right? All right, now the structure of the spine. I was going to talk a little bit more about the spine. I think I've already covered most of this, but was going to have the spine model, but it's probably not. It's not all that needed.
I'm sorry. Well, I'm sorry. I'm sitting over here thinking about what you're saying. So, in your model, what you think is going on is the guy comes in. He's got acute back pain because he foobarred his squat the day before, and you think that he has a piece of the connective tissue, the joint capsule of the facet joint, intercalated between the facets or somehow trapped in the facet space, and then when you manipulate them, you're releasing that?
Yeah, that we do a technique to open that joint up. And we test that by putting our fingers on that facet joint itself, and if we press down on that, which would close that joint, and it causes pain, then that tells us that they have, and it doesn't want to move a lot, that tells us that they have a closing restriction, that they don't want to close, maybe because they have something kind of blocking that where they don't want to close anymore. Then we go to the other side and we push down on that, which causes this to open up just a little bit. And if that causes some relief whenever we do that, then that tells us, hey, let's pop this guy's back and he should be fine.
If it doesn't work, do you blame the meniscoid instead? You say, well, that shit didn't work, and so it must be the meniscoid instead? Or I mean, how often do you find that I'm asking for a percent. How often do you find that actually works?
It depends on the patient, but for more kind of athletic populations and people with acute, like very acute onset, unilateral back pain that I can reliably reproduce with mechanical manipulation of the spine, probably 3/4 of the time.
I'm learning something here. I guess I always thought of a facet tweak as you basically tweak the articular surface. That you injured the articular surface, and it's not going to feel better until the articular surface has had a chance to heal and that articulation becomes more smooth and painless. But you're talking about actually the joint capsule being somehow...
Yes, and whenever we do the manipulation, probably maybe 3/4 of the time, they have an instant relief of pain, and they may have a little bit of soreness, especially whenever you really try to close that joint down, which we think maybe because the connective tissue surrounding that, the joint capsule, is richly innervated, it's richly vascularized, that there's probably some degree of soft tissue injury there. Potentially, if you had a really bad, you really bombed a squat and you kind of rotated as you went down or something like that, I could definitely see where you can end up with an articular cartilage injury. I would hope that that's not the case because, well, let's face it, guys. You're issued one set of articular cartilage when you were born, and you don't get to exchange that. All right. I would like to be the guy to come up with a way to regrow that shit. You know, because
that's interesting. Thank you.
Yeah. So
Can I ask
that kind of changes my picture.
Question is that we as a group have tended to be kind of a blanketed, bigoted statement that what gets done often at chiropractors is a lot of times a little bit on the witch doctory side, doesn't necessarily fix anything, a lot of times adjustments and things like that. You would say that this is really the one place where getting an adjustment would actually truly fix something.
If you were asking me for my particular thoughts on when I would seek the services of a chiropractor, or what I would be looking for, or even a physical therapist that wanted to do a manipulation on my back, one thing that I would look at is does this person think that it's 1 or 2 treatments and that's all that they're going to have to do? If I went into a practitioner and they said, hey, look, man, like I gotta take some x-rays, and then, you know, depending on how bad it is, you may have to come in 3 times a week for the next 9 months. Yeah, because I got to retrain your spine so that this doesn't happen again. I would be...
It's like, how many chiropractors does it take to change a light bulb? Just one, but it takes 30 visits.
And I would perhaps be a little bit skeptical if I went in, and, you know, as a medical provider, they're probably going to ask you some, like, kind of systems review type stuff. If somebody's tried to tell me that, hey, not only do we need to do this to make your back feel better, but we also need to make sure that you continue to come in because, you know, spinal manipulations and keeping the nervous system in line will keep you from getting diabetes or cancer or something like that, I'd say, yeah, I'm sorry, I'm going to go ahead and move out. And it sounds crazy, but I live on the island of Oahu right now, near Honolulu, and there is a recurring advertisement on the radio from a local chiropractor that says to the effect of, not many people seek the services of a chiropractor. Is it any surprise that we have increasing rates of heart disease, cancer, diabetes, and
death by all causes.
yeah, and I mean there's just like in medicine, chiropractic, physical therapy, there's quackery all over the place. If you want to see like what I truly believe is like the biggest quack that has ever lived, just go on Google and type in John Barnes PT. All right, and then that shit is fucking crazy. Like,
I was going to say, Will, you know, if as a therapist the patient comes in and they meet a certain criteria, I think what you're saying is they meet a certain criteria.
Yeah, absolutely.
Through your clinical exam, and they have mechanical low back pain, and it's acute onset, and it's unilateral, then most of those patients are appropriate for a manipulation. They may have some residual symptoms from the inflammatory process, from, you know, the compression of that joint and everything else. That patient can be fixed very, very quickly, but that perspective is totally different than a chiropractic model approach, where there's a subluxation,
Yeah.
and I need to work that subluxation out over time, and then I need to retrain you and all this other stuff. We want to go in, fix the mechanical problem, and then get them lifting again.
and it's, you know, you look at maybe you could look at it as like placebo effect or whatever, or you could just look at treatment effect, right? That somebody has hypothesized that this is what's going on. If you come in, if Dr. Sullivan comes into my clinic and says, hey, I got this unilateral back pain, I bombed out on a squat, and I do my examination and I can reliably reproduce that. So I've now categorized him as being appropriate for manipulation. And I manipulate his back, and the next day he comes in and he's 95% better, just maybe some lingering soreness. Like, in all honesty, does it fucking matter if there was a meniscoid or whatever? Like, it doesn't really matter. We're just coming up with...
From a perspective, it doesn't matter, but I got to tell you, just listen, I mean, I have actually never heard this idea before, that with a facet tweak, what you're actually doing is impinging or entrapping soft tissue in the facet joint or around the facet joint in some way, because then it totally makes sense to me why doing a manipulation might result in a significant improvement in mechanical low back pain.
Can I offer another hypothesis?
Is anybody going to stop you?
All you have to say is no.
No, please go ahead.
Some of you may know that I had that little table in my middle room. I've kind of been an amateur chiropractor for quite a number of years now, and I've adjusted several hundred backs, and I'm better at it than the vast majority of chiropractors. I really am. Some of you, I've adjusted some of you, well, right? I mean, I've worked on people several times. Several people in here. My thought on that is, I don't know that it is so much an entrapment as it is an impingement because of swelling due to the inflammatory response in that tissue to the injury. And just like massage often works to break up inflamed tissue, tissue that's in the process of granulating and is a little larger than normal. A chiropractic adjustment can disrupt local inflammation and provide immediate relief. Because I have experienced it myself, and I've helped lots and lots and lots of people for no money whatsoever, who have gotten up off of the table and were 80% better than they were 5 minutes ago. I know it works. I don't know why, but my thought has not been so much that you've got an actual entrapment, but that you've got something that's big that I can make smaller with the adjustment. And I don't know if that comports with modern thinking on this or not, but that's been my assumption.
I don't have this in my references, even though it's like something that I have it on my desk at work, but there was a study that was done where they took tissue samples of areas of like that people had an MRI that showed some degree of like increased signal or increased fluid, which would signify inflammation, right? And they took tissue samples at these different sites, and virtually none of the time did they ever find any inflammatory cells there. So the conclusion by the authors, and I have to get that study, but they said that what we think of as inflammation may not actually be the inflammatory process that we think, that it may not be as prevalent in the body as we think it is whenever it comes to soft tissue type injuries. But then we get back to this, like, if it's swelling, if it's swelling from the soft tissue injury or inflammation, or if it's kind of a displacement of this discoid material, or if it's an entrapment, if it makes you better, like, it doesn't really matter. Like, we're all just kind of coming up with maybe some type of plausibility, rather than you just come into my clinic and I say, hey, your back hurts, I'm just gonna fucking twist you around and make it pop, and then you're gonna feel better. And you say, well, why? And so I always caveat it with, like, hey, this is what we think is going on. And for most people, any one of these explanations, like, makes enough sense to where you don't think that I'm now telling you that you've got this subluxation complex that's going to cause you to get diabetes, right?
I don't want to step on you if you're going to get into this later. So if you have a client who has chronic or recurring back pain, is it even appropriate to send them, to a physical therapist along those lines, or are you going to get to that later? I'm
going to get to that later, and I'll get into kind of the bigger topic. There is, it's stratifying or categorizing, like, patients, right? If you've had, I get a consult come across my desk because I approve consults for my physical therapy clinic. I get consults multiple times a week that says, patient with, and it's guys like, Dr. Baraki over here that fucking put these consults in, but it says, patient with 20 years of chronic neck, shoulder, elbow, low back, and bilateral ankle pain, please evaluate and treat. And I'm like, fuck, are you serious, man? But then again, I can't blame them, because what's anybody going to do, right? So kind of what happens is patients with that type of a profile kind of get bounced around a little bit until they actually find a provider that kind of thinks about things the way that we're going to end this presentation with. All right. Last thing with the structure of the spine that I think is important is this red line right here signifies where the pars interarticularis is. And the pars interarticularis is important because we have individuals that come to you that have something called a spondylolisthesis. The vast majority of the time, people have had a spondylolisthesis and they've been living their life with no problems. They don't even know that they have one, and it is almost always an incidental finding. But whenever you see it on x-rays or on an MRI, it is an abnormal finding that has to be communicated to the patient, and it sounds really bad. I've had 3 or 4 patients that have come in found to have a spondylolisthesis that had nothing to do with their back pain whatsoever. And they come in and they say, yeah, my doctor told me that I broke my back. It's like, holy fuck. Like, damn it. Because, like, what's the chance that I'm going to tell them, like, yeah, I mean, something's fractured, but it's not what you think it is. It's really no big deal. Don't worry about it. You've had it for years. You didn't even know it was there. All right, so let's talk about patho anatomy. All right. All right, so if you look at the clinical practice guidelines for the treatment of low back pain, their first recommendation is that clinicians or practitioners should stratify people into pathoanatomical kind of categorization, okay? So what we've got is we've got three classifications whenever we look at a purely pathoanatomical approach, all right? So the first one, and y'all are gonna have a really hard time seeing this. Is that a little bit better? Okay. Yeah, so the first one is going to be nonspecific low back pain, all right? Next one we're going to have is potential for radiculopathy. And is there anybody in here that doesn't know what a radiculopathy is? Okay, not as many as I would have expected. A radiculopathy means radiating symptoms, all right? It just means, it doesn't mean it's ridiculous, it just means that it's, radicular means that it radiates, okay? So people with a nerve root impingement will have symptoms along that nerve root, and those symptoms radiate down the leg, okay? So that's the easiest way to see that, or to understand that. So potential for radiculopathy or spinal stenosis. So stenosis just means a narrowing. So yeah, not good. Not good if you have like a true like acute onset spinal stenosis or mass effect on the spinal cord. That's not good, okay? So you can see like non-specific low back pain, potential for this. You can see that there's an increase in severity here, right? And then the third classification would be back pain. Essentially back pain with another specific cause, all right? Now, whenever you look at the non-specific low back pain, we can further categorize this into degeneration, and most of the stuff that you guys see, you're going to end up seeing most degeneration, right? Because whenever we look at the epidemiology and the prevalence of degenerative spine conditions, like fucking everybody in here has it, all right? Like let me just go ahead and save you the suspense. Everybody in here has it, all right? So you can categorize non-specific low back pain into degeneration, and then we can further classify something called disc derangement. And with disc derangement, we're just saying that there's something wrong with the disc that's not anatomically sound, all right? Now, from just a purely like statistics perspective, what would you say the prevalence of non-specific back pain is? Whenever you look at 100% of back pain patients, about what percentage is non-specific low back pain? 90. Pretty close, 95%. 95% or so, all right? Radiculopathy, and it's probably 3 to 4%. And then what do you think the chances are that somebody comes in, person comes in with low back pain and they have cancer in their spine? It's not that high, all right?
Well, I think part of it also depends on your clinical setting.
Yeah, it depends on your clinical setting, right? Because, most people are not going to come into my clinic with metastatic disease in their spine. It does happen. It does happen. I was actually just telling Dr. Sullivan about a case that I was aware of, a patient that I had treated that actually went to a physical therapist with metastatic disease in his spine, got a manipulation, and the manipulation fractured the guy's spine along the tumor margin. Yeah, that guy's no longer practicing physical therapy. All right, so I put this stuff, these kind of buzzwords up here, just so you know, like, whenever you see any of these things are degenerative conditions, all right? And so when people come in and they tell you, I was told that I have a Schmorl's node at, L5. You're like, holy that shit, that sounds bad. It's really not. It's just a degenerative thing, and we see it even though it's not normal. It's so common that it's almost abnormal to not see this type of stuff. All right, so. Yeah, dissolving disc disease is that it's this back pain with other cause because something's fucking really wrong with you. It's just, whenever tissue's just dissolving, you've got some weird shit going on that. So at that point, I say you're not appropriate for physical therapy. Get out of my clinic before you just dissolve into like this mess I have to clean up later, okay? Now, whenever you look at degenerative conditions of the spine, generally speaking, it would be very hard for me to come up with an instance where this isn't the case. It is safe to train with these degenerative conditions. Generally safe. So if somebody comes into you and they say, hey, I was told my life is over, I have degenerative disc disease at L5S1, I guess I can never squat again. You can say, bullshit, the way that we're gonna make you better is we're actually gonna have you start squatting again, and guess what? In 6 weeks' time, you're gonna be stronger and you're gonna feel a whole lot better, all right? Whenever you look at degenerative processes, there's a couple of treatments that are actually fairly effective for it. Number one is non-steroidals, right? Non-steroidals for any type of arthritis is fairly effective, all right? So that's considered frontline treatment for any type of degenerative spine condition or any type of degenerative joint disease, all right? People who, if we're gonna say that this is what's causing their problems, any of these things, what these people are gonna complain about is they're gonna complain about stiffness. It's not so much pain, it's stiffness and maybe discomfort that gets better with exercise, or whenever they wake up first thing in the morning, they're like this and their back is stiff and it kind of hurts to move around, but after 15, 20, 30 minutes, like they feel much better. They feel really good whenever they exercise, but whenever they've had a period of inactivity, like life sucks again, okay? That right there screams degenerative disc disease, and oh my God, it's fucking mind-blowing. If it feels good whenever you exercise, then maybe you should do a little bit more of that, right? If it hurts whenever you sit on your ass and check Facebook for hours and you get up and your back hurts, like maybe do less of that and maybe exercise more, okay? And whenever we talk about exercise, like we're not all that specific. Just do something, all right? And for pain, take either some Tylenol or some NSAIDs and you're going to be fine, all right? That's as severe as this really is, all right? And I put this in red, spondylolisthesis. I put that in red for two reasons. A spondylolisthesis that is a stable lesion. That means that they found this slippage of the vertebrae on the other, all right? Let me get rid of this because we're good here. And I wouldn't have made a big deal about spondylolisthesis, but it's come up on the board several times. And it's very poorly understood because if something's generally found as an incidental finding, it's generally just incidental, all right? Very few times are you ever gonna see one of these that's an unstable lesion. But if we just look, so there's a couple of things that I'm good at, there's a couple of things that I'm not good at, all right? And art is one of those things that I fucking really suck at, all right? So you just have to, just believe me that these are supposed to be these are supposed to be vertebrae, all right? So we talked about the pars interarticularis, which is a part where the facet joints kind of meet up. It's something that kind of becomes the facet itself. Those fracture and that allows some translation of this, all right? So whenever you look at a spondylolisthesis, they're gonna grade it. It's gonna be graded 1 to 4. All right. There's also a fifth one, but if you come in with the fifth one, like generally speaking, like you're not coming to a physical therapist. All right. So a grade 1 is somewhere between. So let's say this is the segment that's actually translated, right? So a grade 1 spondylolisthesis is somewhere between 0 and 25% slippage. All right. A grade 2 is going to be somewhere between 25 and 50%, all right? Grade 3 is somewhere between 50 and 75%, and then a grade 4 is going to be somewhere between 75% and 100%, all right? So as you can see, depending on the grade, can actually tell you a lot about what's going on. Grades 1 and 2 that are stable, generally safe to train, all right? And how are you going to know that that's stable? There's a couple of things. Number one is that once they find this, almost always they're going to have a follow-up or an interval x-ray to check for change, all right? If somebody's very symptomatic, they have a lot of back pain, they'll have an x-ray, it shows us, oh my God, they've got a spondylolisthesis. And then what they're going to do is they're going to re-image them 6 weeks or maybe 12 weeks later to see if there's any change in that slippage. If there is, it's now an unstable lesion, and they're probably going to go to a surgeon, and a surgeon's is going to fuse this, all right? Now, the 5th grade is what's called a spondyloptosis, all right? And what that means is, we'll say this is the reference one. A spondyloptosis means that the facet, or the vertebrae is now like this. It has actually gone over the edge of the other one. They're probably not coming to you to look for training, all right? I've seen one of these that was largely asymptomatic. It was kind of an incidental finding. This person still went in and had a fusion done, because this can get bad really quickly because spinal cord goes right there. And that's not the preferred technique for how you want your spine, all right? All right, but anyways, this question comes up all the time, that people say that they have a spondylolisthesis, and generally speaking, the thing that we tell everybody is like, hey, if it's a stable lesion, it's probably fine to train. If there's ever any change in that, because somebody can have a stable lesion that becomes unstable, right? Then now at that point it needs to be reassessed.